Good morning, everyone, and welcome to our Maternity Matters webinar today on hypoglycemia. This is the first of our bite-sized format and has been devised to focus on a single subject with a single eminent speaker. My name is Anne Kavanagh. I'm a partner solicitor in the Irwin Mitchell London office. And I'm joined today by Dr. Jane Hawdon, who's an eminent neonatologist and expert on this subject. I will give Jane's full introduction shortly after I've spoken a little bit about the legal background to these issues and the claims which arise from them in our experience. Just a little bit of housekeeping. Thank you to those who have already submitted questions on the registration form. You can submit additional questions throughout the webinar using the chat function, the Q&A function on your screens. And at the end of Jane's presentation, we'll go through those questions and answer as many of them as we can within the time. We will be recording this as well, so within a couple of days, the recording will be sent out to all of you who've registered. And towards the end of the session, we'll post a feedback link again in the Q&A chat. And please do give your feedback because that helps us to devise the next and the forthcoming series of bite-sized webinars. In terms of questions already submitted, if we can't get to them today, in the Q&A box or chat, do provide your name and email and we can address them afterwards and email the response to you. So moving on then, the legal context is, I guess, retrospective by definition, because properly treated and properly identified and corrected, hypoglycemia will have no long-term effects. But I will speak briefly about those cases we see and the clients we hear from where damage has been caused, often sadly with severe disability as a result. In terms of how these cases reach Irwin Mitchell and are reported to us by parents, we hear from a range of parents whose babies have suffered permanent brain injury as a result of untreated hypoglycemia. From those who were already at risk of their babies developing the condition, but it was missed by others, often often new mothers who complain that they had very little, if any, support with feeding and their concerns about their babies were dismissed. I would also say that those second category of clients tend to be greater in number, and there may be many background factors to explain that. I don't think any of us could be unaware of the staffing crisis in maternity care at present, and that may well be a contributing factor. But whatever the background, these families come to us in desperation. And mothers are often describing events to us in retrospect, where their child is now disabled, but they are, as you can imagine, haunted by feelings of guilt that they didn't speak out enough at the time, often mixed with anger too, that when they did raise some concerns, those concerns were dismissed or they were falsely reassured. And in those cases, there's often a dispute between the parents' recollection of events and the maternity records, which I'll come to later in one of the case studies. And so this brings me to a recap of the test in negligence in these claims. The test requires, it's a two-pronged test. First of all, we have to establish breach of duty, the so-called Bolam test. And this is a test against whether the standard of care provided would be supported by any reasonably competent practitioner. This is not a standard of perfection, and the standard against which practice is judged will depend on the professional standards in play, as well as local and national protocols and guidance. And then we have to prove causation, the second prong of that test. that on a balance of probabilities, the negligence or substandard care that we've identified through applying the Bolam test has caused the injury complained of, or put another way, with reasonably competent care, the injury would have been avoided. Next slide, please. So in relation to hypoglycemia, the standard which applies will often depend on the gestational age and condition of the baby at delivery, and if born well, the standard may well relate to the application of those local trust and NICE feeding guidelines. The themes which recur in our caseloads include failure to recognise risk factors, a failure to recognise and maintain blood sugar testing in babies at risk, and the challenge of identifying and monitoring and, if necessary, treating reluctant feeders. So those babies that we see, or the cases that emerge and become claims, often involve where there's a failure to recognise risk factors, a baby who is preterm, and those with either low or high birth rates, or where the mum has significant comorbidities. If the risk is recognised, then the next stage at which these cases fall or become claims is where there's been a failure to maintain regular testing to ensure a blood sugar level of around 2 millimoles per litre. It's accepted that there are sometimes babies who are reluctant feeders, and where we see claims emerge involving those, generally involve a failure to monitor carefully when those early signs emerge, to apply and adhere to the relevant feeding policy and to monitor so as to ensure sufficient blood glucose levels are maintained. Some of our cases involve babies where that reluctance to feed is an early sign of other problems, such as sepsis, or possibly an indication of a pre-birth silent brain injury to the baby. They're not signs of hypoglycemia, but again, the relevant and the appropriate feeding policy would apply and would cover those cases. So the adherence to appropriate monitoring is key to demonstrate that the standard of reasonably competent care has been met. The other factor which almost always comes across from parents is a failure to listen. The mothers and fathers often report that they weren't listened to, that they had concerns, that they weren't being over anxious or difficult, but they were simply not listened to. And again, this will come up in the case studies because that's not always reflected in the clinical records. So next slide, please. So the first case study involves one of those cases where there were significant risk factors. Mum had a history of a connective tissue disorder as well as hypertension. She was on labetalol throughout her pregnancy, and I'm sure Jane will cover this later, but that is a risk factor for a baby developing hypoglycemia. And the relevant NICE guidelines addressing this had been published prior to this baby's delivery. It was the first baby delivered at term by Von Toos. The labour hadn't been particularly prolonged, but had been difficult for mum because of her connective tissue disorder. And at delivery, the baby required some inflation breaths, had some mild acidosis on blood gas, and had poor tone. But this was again attributed to what was considered to be approximately a 50% risk that he would acquire mum's condition. And because of the history, they were admitted and kept in hospital for 2 days post-delivery. Throughout that period, mum was concerned that her baby was not feeding. She was encouraged to breastfeed. The baby, she felt, was not latching on, and she had no sensation of the baby sucking. After the first almost 20-hour period, she was given a syringe to feed the baby, but it was a 1 ml syringe. And by the time of discharge, which was just shy of 48 hours post-birth, the baby was still not feeding in any real sense. She was still using the syringe, 1 ml feeds. And she and her husband were reassured. They were concerned, but they were reassured and discharged. She was seen by the community midwife the following day, who was very worried about the baby, who was taken by ambulance to hospital, and his blood sugar in the lab was recorded at 0.3 millimoles. He had suffered a weight loss of just over 6% from the time of his birth, and he went on to have a prolonged stay in the NICU, and sadly went on to develop significant disability. Brain injury was confirmed at 7 days post-birth. The allegations of negligence in the claim weren't confined to, but included failures to identify the increased risk of hypoglycemia in view of mum's beta blockers during pregnancy, failure to identify poor feeding, and then once identified, a failure to institute measures to ensure feeding was established and to monitor blood sugar levels in view of the pre-birth risk factors. And then finally, discharging before feeding had been established at all. The records, when they were obtained, consistently reported by staff that the baby was latching on and feeding well. This was inconsistent with the parents' account, and there were no records of blood sugar testing. Nevertheless, liability was disputed throughout on the basis of the records and this clear inconsistency between the records and parents' accounts. Liability, as I say, was disputed. The matter went to trial, but settled on day 3 of trial following evidence from the midwives on duty at the time, who couldn't explain the baby's condition against the actual records made. As I say in the slide, the baby suffered a severe brain injury, has motor impairment, epilepsy, vision impairment, and cognitive and behavioural issues which are severe and lifelong. The other issue, and Jane may have a view on this later on, about these cases, I should say, is that in my experience, they tend not to, or rather put another way, these children tend to have relatively long life expectancies. And as a result, when we talk about the need for lifelong care, that is very expensive. It is pretty devastating to families. It's not unusual for family breakdown to occur between parents because of the strain of all of this. And in this case, for instance, this matter, as I say, went all the way to a liability trial, which means that those children are often 7, 8, 9, 10 by the time liability is resolved and interim funds become available to pay for some sort of respite, commercial care, and so on. So the strain on families is understandable, I think, in those circumstances. Next slide, please. So this was a slightly different set of circumstances because mum had type 1 diabetes, insulin dependent, and this was her second pregnancy. Her first pregnancy had gone well, she'd been appropriately managed. But in this pregnancy, sadly, she wasn't appropriately managed, and until 38 weeks, she was referred to hospital for poorly controlled glucose levels. She suffered an episode of maternal ketoacidosis in hospital, leading to hypoglycemia and brain injury in the baby. Mum was appropriately treated once the ketoacidosis was identified, but there was a delay, and injury occurred to the baby, which was permanent and confirmed on MRI imaging. The injury included motor and cognitive impairment as well as epilepsy, and liability was admitted after a letter of response denying liability, but just after court proceedings and particulars of claim had been served. Settlement, however, was delayed until after the onset of puberty, when baby B was 17. And that was because obviously the parents were told that the MRI scans showed damage, but they were very reluctant to accept that at the time, and to their enormous credit, put in a huge effort in terms of rehabilitation, early intervention, and so on, to mitigate the impact of that damage in those early years. And as a result, baby B appeared to be doing relatively well by the time she was ready to start school. She was mobile, although clumsy. She was on medication for her epilepsy, but it was well controlled. And although she could not manage stairs safely, she was able to walk and move about outside without any aids. But sadly, her progression through school saw a widening of the gap in her cognitive ability in particular. And experts at the time liability was resolved, when she was 10, concluded that they were unhappy because of the risk associated with hypoglycaemia injury on brain damage in particular. They were reluctant to give lifelong prognoses for her development and so on until she had gone through puberty, because they felt that there were significant trigger factors there which could make her condition worse and more difficult to manage. And sadly, that proved to be the case. The proceedings were stayed or suspended while she grew and developed, and alongside that, of course, she had input from a case manager, a range of therapists, carers, and so on. And by the time the claim settled when she was 17, the evidence was clear that her behaviour, her impulsivity and lack of impulse control in particular, she was prone to violent outbursts. All of those factors meant that she would require likely one-to-one care for life, and at times possibly 2-to-1. Once again, she had an unimpaired, if I remember correctly, life expectancy. So the cost was really high, not just in terms of the financial cost of all of that, which is borne by the NHS, but her parents divorced and separated and divorced because they could not cope with the impact of managing her behaviour and the effect that had on not just her, but her other sibling, her older sibling. So yes, slightly different, I think, set of circumstances which led to her injury from the first case study. But again, the consequences pretty devastating for life. I mentioned earlier my presentation would be relatively brief, and so it is. The main focus of today is to hear from our expert. And Dr. Jane Hawdon has studied medicine at the universities of Cambridge and Newcastle. She is currently a medical director and responsible officer and consultant neonatologist at the Royal Free Foundation Trust in London. She has held consultant and clinical leadership posts at UCL and Barts, as well as regional and national education roles. She holds governance posts as a trustee with a Noah's Ark Children's Hospice and as a school governor. And for the purposes of today, she has been a member of the Independent Reconfiguration Panel, NICE Guideline Development Groups, and the Board of Trustees of the charity Bliss. And she's chaired the Neonatal Hypoglycaemia Working Group of the NHS Improvement Patient Safety Programme. And she was also neonatal clinical lead for the National Maternity and Perinatal Audit Programme. So I will hand over to Jane, and hopefully Donna will move on to the next slide, which is the start of Jane's presentation.
Thank you. Thank you, Anne, for the introduction and those really useful cases. Now, I know that we've got an audience of mixed background, and so I am sorry that I introduced some science, but I think we do need a little bit of science to understand the reality. So you will know that one of the reasons, unfortunately, why we have so many perinatal claims, because we have perinatal mishaps, is because it's an incredibly vulnerable stage of life. We've gone from a fetus entirely dependent on the mother, and apart from certain extreme situations, completely protected by the mother, by the placental circulation. And then suddenly there's the baby having to become independent in so many ways, in less ways than some of our mammalian colleagues, but still independent, breathing independently, gas exchange independently, feeding by mouth rather than through the intravenous route, which was the placental route, and managing the periods of fast in between feeds. And the first of those fasts is, of course, the period immediately after birth. So when you think about the complexity of it all, you're sort of wondering why it ever works. But of course, nature's designed us with a few sort of backstops and safety features that, provided everybody is getting care right, the likelihood of problems is very small. So if we move on, and if I just take this opportunity to, with apologies, I am likely to have to take a call at some stage during the talk, which will only take about 2 minutes. So if that happens, it'll give you a chance to stretch your legs. So I'm going to concentrate on neonatal metabolic adaptation, which is more of a mouthful than hypoglycemia. But the reason that I'm saying that is on the slide here. I'm going to show you that the neonate is, to a degree, dependent on glucose for metabolic fuel, but there are alternative fuels to glucose in the neonatal period. Lactate, which the placenta is providing the baby with a store of after birth, and ketone bodies, which are the breakdown of fatty acids. And again, a healthy baby is born with lovely, chubby adipose tissue stores and a source of fat to break down to form what are called the ketone bodies. And there is ample evidence that the brain can take up and utilize ketone bodies. And that is one of the clever little fail-safes that nature and evolution has provided us with. So whilst hypoglycemia is a shorthand, I prefer not to talk about hypoglycemia. I prefer to talk about delayed or impaired neonatal metabolic adaptation, because we have to look at the whole currency. If we just look at glucose, it's like opening our purse in the days when we had purses and coins. It's like opening our purse and only counting the 50 pences and not counting the 10 pences and the pound coins. Next slide. So these are now some very old data from the time when I was studying for my PhD in Newcastle. And they look at the relationship between ketone bodies and blood glucose level. Ketone bodies on the vertical axis, glucose level on the horizontal. The top chart are some healthy children that were fasted overnight prior to elective surgery. Those whose glucose levels dropped to what would be a low normal range for a child, you can see that they mounted a pretty impressive ketone body response. We all do that. We all do that. And then we've got a group of term babies, absolutely healthy, appropriately grown term babies with no neurological symptoms at all, signs at all. And you can see that there's a much wider range of pre-feed glucose levels. If you look down at the bottom left of the graph, you've got a few dots which are low glucose, low ketone bodies. Those babies were within an hour of birth when they were sampled. If we take those babies out, you can see for the rest of the babies that even if glucose levels appeared to be lower than you would expect for an older child, there was an impressive ketone body response. And this is why I'm saying we can't take glucose levels in isolation, and it's a completely normal finding for a baby's blood glucose level to fall in the hours before birth, to slowly come up again, but to be protected by alternative fuels, provided this is a healthy baby. I'm not going to talk in detail about preterm babies, but you can see again a range of glucose levels, but overall a lower ability to produce ketone bodies when glucose levels were low, which is no great surprise because preterm babies are less mature and they've got less fat, and nature has designed them to still be in their mum getting their regular supply of glucose across the placenta. Next slide. But what is interesting, if we look at a group of babies who were moderately preterm, so 34 to 36 weeks, or term but growth restricted below the second centile, so those are babies that we know are at risk of delayed neonatal metabolic adaptation. So overall, when we look again at their ketone body levels, so what is this baby's ability to mount a response if glucose levels are low? You can see that our breastfed babies, who are the white circles, have got a much higher ability to produce ketone bodies. The formula-fed babies are really low in terms of their ability to produce ketone bodies, and the formula-supplemented babies are somewhere in between, because obviously formula supplemented babies are getting a range of formula intakes. And this has been shown in every group: healthy term babies, babies of diabetic mothers, moderately preterm babies, babies with growth restriction. So the message for this is that we must do our very best to support breastfeeding in our most vulnerable babies. But we must do that against a background of monitoring, so that if the glucose levels are persistently low or there are any clinical signs associated with hypoglycemia, we give them formula supplement as indicated. Formula is a medicine, it's a drug, and we shouldn't be giving any more formula than we ever need to give. And I draw your attention out there to those babies that are receiving almost 180 mils a kilo a day of formula in the first few days of life. That is really unphysiological. We're overwhelming those babies with far too many calories, far too much protein, and we must be titrating our formula supplements against the needs of the individual baby. Next slide. So as Anne said, we've got a group of babies who we know from the time that they are born that they are at risk of delayed or impaired neonatal metabolic adaptation. There may be altered maternal metabolism. In the old days, people used to give mums too much glucose. That doesn't happen anymore. Maternal drug treatment like beta blockers, and maternal diabetes if it's not been well controlled. Neonatal complications, because they affect particularly liver function where glucose is made, can also cause hypoglycemia, and also in turn they can cause long-term difficulties. And so what we want to avoid is an additive effect of a sick baby with infection who on top of all of that is hypoglycemic. So we need to be well aware. First of all, unexpected low glucose levels associated with clinical signs may well be indicating an other underlying disorder. Secondly, if we're managing babies for any of those conditions, we pay close attention to their glucose levels and manage accordingly after birth. Growth restricted babies, and I stress that these are growth restricted babies, not small round babies. I'm a small round person, I've had small round babies. You're more worried about the long skinny baby who was destined to be a plump baby who has come out growth restricted. So take your clinical observation into account. Where I first did neonates, there was a really good thing on the admission pro forma for every baby for the postnatal ward, with an evaluation of the state of nutrition of the baby. And it wasn't, is this baby going to breast or formula feed? It was, how well nourished does this baby look from the moment of birth? Neonatal hyperinsulinism, high insulin levels, may arise from maternal diabetes, or they may arise as a result of a problem with the baby's pancreas. Could be transient, could be prolonged. When it happens, because insulin suppresses the release of fatty acids from adipose tissue stores, that's sort of the worst sort of hypoglycemia to have, because we're not able to produce our alternative fuels. And then rarely endocrine disorders, inborn errors of metabolism. You may have some warning because there may be family history, or they may present as unexpected severe hypoglycemia, in which case our job as clinicians is to make sure that we investigate for underlying causes, because we need to protect that baby through the rest of their childhood and adult life. Next slide. So, as Anne says, absolutely true that unfortunately prolonged and severe hypoglycemia can cause brain injury. And this is an example. You may not know what sort of normal brain scans are looking like, but in the posterior areas, there are abnormal areas of shadowing in a baby that was only 5 days old who had sustained quite severe hypoglycemia. All of the evidence is that if the baby has no clinical signs at all, even if the glucose levels is low, it's highly unlikely that that baby is going to get brain injury. And my sort of simplistic take on that is, if the baby is functioning normally and behaving normally, that baby's brain must be burning something and therefore be protected. We can only say that if we can put our hand on our heart and say that we have made a thorough assessment of that baby's clinical condition. And Anne gave you some examples where that hadn't happened. And inability to feed effectively is in itself a clinical sign of a neurological abnormality, so must be taken seriously, because it could be a cause of hypoglycemia, but it's also a potential clinical sign of hypoglycemia. Also a clinical sign of infection or other underlying disorders that need to be investigated and treated. Next slide. So this is the same baby, older in childhood, and you can see very marked appearance in the posterior areas. And one of the reasons that we have very often visual impairment in babies who've sustained hypoglycemic brain injury is because the occipital cortex is the area where the brain sees the signals that are coming through the visual tracts from the eye. Next slide. So I'm going to refer you to some really important publications arising from the NHS patient safety work that many of us were involved in, and it was work that looked at reducing morbidity for term babies and preventing unnecessary admission to neonatal units. So there was a work stream for infection, there was a work stream for jaundice, there was a work stream for hypoxia and a work stream for hypoglycemia. Arising from that work stream was a recommendation that we would ask the British Association of Perinatal Medicine to develop a framework for practice, and that duly happened with a neonatologist and a midwife co-chairing a completely multidisciplinary group with input from really all the relevant parties, and then a very, very wide consultation. It was published in 2017. It was reviewed and republished in April this year, with in April really very, very few changes compared to the April 2017. So the guidance in effect has been in place since 2017 and has not changed since then. And one of the major emphases on the guidance is about the partnership between parents and staff in the management of babies across the board. Next slide. So, as I say, really, really broad consultation. And we know that it's a really emotive issue. We know that the inability to completely breastfeed, to totally breastfeed and have to introduce some formula is not favoured by some parties. The risk of getting brain injury is also something that is very high on people's agendas. So the whole thing, the framework for practice and our clinical management is all about balancing those risks, which is what clinical practice is always about. Next slide. So the recommendations were to list those babies with risk factors, pretty much the same as I had on a previous slide. Recognising that babies with no risk factors may develop significant hypoglycaemia, either because they've got an unrecognised underlying disorder or they are so short of feed that their reserves run out. Then very important to have appropriate care pathways for babies that have been identified at birth. And there are some brilliant examples. In where I work, there's what's called a Red Hat project, and a baby who needs to go on one of these particular pathways gets a red hat, so that if they're on the postnatal ward with their mum, everybody knows this is a red hat baby, and we just keep a closer eye on this baby and make sure that we look at the care pathway. We all know that breast milk is the absolute best source of energy, and that formula is associated with longer term difficulties, particularly if given in excess. But like any drug, sometimes it is necessary to give it. But as I said in my previous slide, really important to minimise the volumes that we give. And this lovely part, if you haven't read the framework, I really recommend that you do, about parents being partners in care and making sure that they have verbal and written information, and in turn they are providing information to the clinicians involved in the care of the baby. Next slide. So, I think have we gone back, or is that a duplicate slide? If we just go on one. There. So yes, that was to remind you of the risk factors. Really important that we do accurate and rapid measurement of blood glucose levels. So I know, Anne, that you were sort of slightly interchanging blood sugar and BM. Can we try and take BM away? BM is a particular machine, a particular stick that is really, really inaccurate for measuring low glucose levels. So talk about BS and BG and talk about accurate blood sugars, accurate blood glucose levels. We then looked at operational thresholds, the levels at which you would want to intervene. Buccal dextrose gel as a rapid treatment for hypoglycaemia has really come online in recent years. And it's really important that severe hypoglycaemia or persistent hypoglycaemia or hypoglycaemia associated with abnormal clinical signs is a medical emergency and requires immediate medical review and investigation. And I say, if you're a midwife on the ward and you're worried about hypoglycaemia and you're not getting a medical response, if you can, take the baby to the neonatal unit yourself. Don't wait for the doctors to turn up. And as Anne says, really important to distinguish between abnormal feeding babies and a reluctant feeder. And we do really need our skills of our midwives here to be able to say, I think this is a reluctant feeder, we give lots of support, we think this is going to be all right. Or do you know what, this has been going on too long, and this baby, there's more to this baby than just being a reluctant feeder. Again, the more we get our heads together, if it's an experienced mum, how did she get on feeding her previous baby? Is this baby different? The more we get our heads together, the more we share information, the more effective this is going to be. Next slide. So this again is a very old slide. It's my rant about BM sticks. So if you compare two methods of measuring the same thing, you plot them on this sort of plot, which is called a Bland-Altman plot. This is a laboratory study taking blood samples, and if you see they're at low glucose levels, and using a laboratory measurement, an autoanalyzer, and using a Reflux machine, which is like a BM stick machine, and near patient testing. And the difference between the two is plotted against the glucose level. If the near patient testing was as accurate at the laboratory, if we had a live audience, I would say, where should all the points lie? I'm hoping you're thinking they should all lie along 0. The values should be the same. There should be no difference between the two. Where do they lie? All over the place. So if you do near patient testing and the glucose says 2 on the near patient testing, the real one could be 1.5 or 2.5. And if you have diabetes and your glucose stick says 8, you don't really mind if it's 7.5 or 8.5. You do know what you need to do. If you're a baby, the difference between 1.5 and 2.5 could mean the difference between brain injury or not. It could mean being taken away from your mum when you don't need to be taken away from your mum. So increasingly, it's been recognised that neonatal unit blood gas machines are sufficiently accurate to do this, and therefore we should be using accurate methods. The old guidance used to be, if the near patient testing is low, send a sample to the lab. That just results in stabbing a baby twice and delaying any treatment. So go straight for the accurate method straight away. Next slide. Our operational thresholds is that, next slide, the concentration of glucose at which we should consider an intervention. There is no magic number. There's no magic number to consider an intervention. There's no magic number that sadly causes brain injury or protects from brain injury. Next slide. And what's interesting is that after this working group looked at all of the available evidence, they stuck with a publication that was published in 2000 by people from both sides of the Atlantic who recommended these operational thresholds. Glucose below 1, baby doesn't touch the sides, it gets treated. A single value below 2.5 in a baby who's got risk factors, or glucose is below 2 persistently if there are no clinical signs. Clinical signs, baby doesn't touch the sides. So again, those are there in the framework for practice, and I think they provide very useful guidance, which hopefully will avoid over extreme interventions and also encourage us to think. Next slide. So my screen is breaking up. Is anybody else's screen breaking up?
No.
No, I don't know why mine is. Okay, so again, you can read those, and really important, as I said, around the feeding behaviours. These are all there in the framework for practice. Next slide. And it's really important to identify and document risk factors, the glucose levels that have been accurately recorded, the feeding patterns, the clinical signs, and the absence of clinical signs. Well-documented absence of clinical signs are really important in terms of sort of later reassurance that the right thing was done, provided they're accurate and provided somebody can stand up in court and say that they're accurate. And think about your investigations for underlying pathology, and again, document those. Some of those results come back late, so make sure, those of us that are doctors, we know that it's GMC guidance that if we request a test, it is our responsibility to make sure that that test is followed up. In the terribly tragic and shocking circumstances of the Lucy Letby case in the Countess of Chester, 2 babies were poisoned with insulin. Those insulin results came back a long time after those babies died because they were done in a specialist laboratory. This is in the public domain. I'm not sharing any secrets. And it came to the consultant's attention really very late. And so it is really important that if we've asked for investigations, if those babies hadn't been poisoned and they truly had hyperinsulinism, it was equally important to know that their insulin levels were high and to make sure that they had the right treatment. Next slide. So again, I would refer you to a paper in Archives of Disease of Childhood in 2017, and that again came out of the patient safety work, and again was a fantastic collaboration between the NHS Litigation Authority, now NHS Resolution, midwifery and neonatology, to look at the cases that had been successful claims. And we looked through all of the papers, all of the findings of the court, the expert reports, the parent statements, and we identified a number of themes. And again, I hope it's a relatively easy paper to read. I'd encourage you to read it. But the sort of things that Anne was telling us is largely around parents not feeling listened to. And the other thing I would just pick up on Anne's cases, I hate syringe feeding, and I hope all of you out there that are clinicians also hate syringe feeding. If a baby isn't able to feed by mouth, and by that I include cup feeding, because the baby still has to have competent feeding reflexes to cup feed, the baby shouldn't be getting milk into its mouth and its airways. And squirting milk into babies' mouths is a really risky procedure if the baby is not competent to orally feed. And if you're thinking, if I'm needing to use a syringe, what's going on with this baby? If I had my way, the syringes would stay in the IV cupboards and would go nowhere near milk unless it was to be gravity feeding a baby on the neonatal unit. So, next slide. So these again are just some other examples of some of the comments and learnings and lessons that were taken. And I think you're going to get the slide set, so you'll have your time to read these. Next slide. And again, just coming back to why are these things important? I'm going to stray slightly from hypoglycemia. I'm going to talk about unnecessary admissions to neonatal units. This is some work from the National Maternity Perinatal Audit, and this is showing you the enormous range of percentage of term babies admitted to a neonatal unit. Now, we know that, for example, if a unit is a neonatal surgical unit, it will have a number of term babies admitted because they have known surgical problems and are referred to that unit before they're born, which is why we've separated those out. But apart from that, we really would expect the term baby population to have no different risk factors across the entirety of the neonatal units, and yet look at this phenomenal range of variation. And we talk about unwarranted variation, and I think this is an example of unwarranted variation. And for every one of those dots with a higher than expected, that's a baby taken away from its mum. It's a baby with a longer than necessary duration of stay. It's a baby whose mum is going to have to struggle much harder to express and breastfeed her baby. I've had 2-term babies, I've had a preterm baby. I know the difference, and I know the grit and determination required to provide breast milk for a baby that you are distant from, and then to establish feeding with a less mature baby. So this is really important. Next slide. And not surprisingly, around the sort of moderate preterm gestation, that level is really high, but it's still significant in the beyond moderate preterm gestations. It still counts. Next slide. And this is where the ATTAIN programme, which is the NHS Improvement Programme, came in. And I told you many of us looked at many different things that result in babies getting admitted to neonatal unit. Next slide. And we looked particularly at admission that wasn't warranted. We know that term babies get poorly, sadly. We know that they might get a congenital infection. We don't want to avoid admitting term babies for treatment when they need treatment. Next slide. And so if you just scroll down all the way through to get all the bullets. So 12% of all term admissions were for management of hypoglycaemia, or were listed as management. Babies born by caesarean section were overrepresented, and again, I'm sure that that's no surprise to you clinicians. And 39% of those babies admitted for hypoglycaemia were actually low-risk babies. 30% were admitted when they were less than 4 hours of age, which is at a time when, as I told you, the glucose level is going to be low anyway. And so I think that is a sign of measuring a glucose level when you don't need to measure a glucose level. Of course, if you're worried about the baby, measure, but there are a number of babies who, the baby's having a heel prick for something else, somebody takes a glucose, and then they end up going down a hypoglycemia pathway that they don't necessarily need to go down. Next slide. A lot of babies admitted after diabetes in pregnancy were admitted before 4 hours of age, so before they'd had chance to get their milk feeding established. And many of the babies admitted after diabetes in pregnancy actually had a perfectly normal glucose level. And at that time, there were still some babies who routinely admitted, babies of diabetic mothers, even if they were really well. 65% of the babies admitted after maternal diabetes didn't need glucose infusion. If all they needed was milk, they could have stayed with their mum. And this rose to 86% of those who were admitted within an hour of birth, indicating that they didn't really need to be admitted. Next slide. So the NHS Improvement produced some really good resources to reduce harm leading to avoidable admission of full-term babies. Next slide. And some really good guidance for post hoc review to then allow your department, your unit, to think, what can we do to reduce this? So this is a checklist. You could look at babies admitted with hypoglycemia. Actually, did that baby really need admission, and how could you have avoided it by going through this checklist? Next slide. So those are a summary of the science, the clinical guidelines, and the why this is really important. It's important to avoid injury. It's important to keep mothers and babies together. And those things are not mutually incompatible. It can be done. Thank you very much, everybody. Take questions, and I'm sure Anne will take questions as well.
Thanks very much, Jane. I'm just looking at the questions which were submitted prior to today's webinar, and I think you probably have addressed a couple of these already in your presentation. One of them from a mum working from home was whether lessons have truly been learned by the NHS from past mistakes. And I can see from your work
a big question. I'm old enough to have been involved in this for quite some time, and because of my research background, obviously my ears prick up around metabolism and hypoglycemia. Touching everything, I think the hypoglycemia claims are reducing. There will sadly still be some practices where mums have been ignored or people haven't followed guidelines. I do think lessons have been learned, and I do think bringing everybody together with the BAPM framework, the ATTAIN work, to have truly multidisciplinary and the parent voice in this work has made it so much more powerful than some doctor somewhere saying this is how it all should be done.
Yeah, yeah. And that sort of leads into another question from Sue Haddon at the Infant Feeding Alliance, which was whether a policy that promotes exclusive breastfeeding and the withholding of formula supplementation ever be safe with regard to hypoglycemia prevention.
I have to say, I did see that question. I have never seen a policy that promotes exclusive breastfeeding and avoidance of formula. Policies promote breastfeeding and say, if you can, exclusive breastfeeding is absolutely the best thing to do, but we know that there are times when formula is needed. Again, the two are not diametrically opposed. And I showed you that slide of the moderately preterm and growth restricted babies. And there is something called the Hawthorne effect. And many, many years ago, there were two factories and they wanted to look, I'm getting there, don't worry. They wanted to look at whether lighting, background lighting made a difference to productivity. So one factory had better lighting, one factory had normal lighting. In fact, both factories increased their productivity because they were both in a study and they were both being watched effectively. So these two studies that I've just told you about, an absolutely amazing midwife called Suzanne Coulson and an absolutely amazing neonatologist called Laura DeRoy were the research fellows involved in those projects. They were there on hand to support those parents so that they could really support those mums with breastfeeding, recognising that breastfeeding a smaller baby is a bit more tricky, and were there to keep a very, very close eye on clinical signs so that they weren't unnecessarily given formula. So these babies were really privileged to be in those studies. And that is why some of those mums exclusively breastfed, because they had so much support. Now, we know that isn't real world, but it's something that we should be aspiring to. It should be as easy to support a mum to breastfeed as it is to decide to go and get some formula and give the baby some formula. One of Suzanne's findings, and she's gone on to publish something that she calls biological nurturing, is that every baby benefits from skin to skin, but the vulnerable babies who take longer to establish their adaptation, who take longer to establish their temperature control, really benefit from skin to skin. And actually, they start to use their primitive reflexes to sort of nosy their way over and start to latch and suck at the breast, which if the baby's in a cot wrapped up, how on earth is it going to use its primitive reflexes to breastfeed? And so Suzanne always says to a mum, you're going to want to hold your baby. You know, you're going to have to be prepared to hold your baby. And I think that's really, really good advice.
Thank you. Another question has come in that a lot of, or the impression this attendee has had is that much of this is down to clinicians being educated and confident enough to make these decisions. And do you think the training given these days is good enough?
Could always be better. I mean, one of the other things that came out of the Attain programme was some very, very good training packages. I think now that we've got sort of very clear user-friendly guidance, you know, that we can now get off the internet and we don't have to go ruffling around finding folders on a neonatal unit. It ought to be there. And I would say that those of you who are clinicians, never miss an opportunity to do a quick teaching session around some of these issues when you're either on a postnatal ward or on a neonatal unit.
And another question in view of feeding, and particularly I'm guessing relating to new mothers or first-time mothers, what about expressing breast milk to be able to monitor the volume consumed? Because I think that is one of the concerns always of first-time mums. Yeah. How do you know they're getting enough?
So with the absolutely healthy baby with no risk factors, there's no point. We know that On day 1, a baby takes about 10 mils a kilo a day. On day 2, takes about 20. On day 3, 30. We know that. And this is where the sort of biological adaptation, the metabolic adaptation comes in. We flung test weighing out a long time ago, and I know what it's like. The mother of a baby who's trying to establish feeding, you feel like you're sitting your GCSEs all over again, and I'm sure that there's nothing more likely to dry up your breast milk than to feel that it's being examined. So the well-being of the baby, is the baby sucking, is the baby swallowing, can you hear glugging, ultimately is milk coming out of the mouth at the end of the feed, is the milk dripping from the nipple at the end of a feed. There are so many ways to establish adequacy of breastfeeding, and the bottom line is this baby a healthy baby with no abnormal neurological signs?
Yeah. Another question is around the guidelines, that guidelines for breastfeeding mothers do ask that if formula is to be given, it needs to be prescribed, because as you've said, it should be considered as a drug. That doesn't seem to be a question, it's rather a statement.
Yeah, I mean, it's again, policies vary. There are some trusts that say you've got to bring your own formula milk in from outside, because they're so baby friendly. We've got to remember that it still could be an emergency drug, and if a little bit of formula helps the baby turn the corner and get lively enough to breastfeed again, it's sort of money well worth spent. So we have to recognise that sometimes formula might be needed and might be needed quickly, but I do agree that the prescription of it makes people think about, why am I doing this?
Yeah. One other pre-submitted question was, and I think this relates to doing blood sugar testing, why is it not considered a standard test when it's such a simple test to be done and can prevent catastrophic consequences?
Yeah. For the reason, if in one of those slides, that actually in the first day or so of life, there's a very high statistical chance of the glucose level being low, because that is a normal finding. And then, of course, you're sort of left with the baby on your hands of, I've got this low glucose and I don't know what to do with it. And I do believe that some babies are over-treated because they were having a test for something else. The glucose level was measured. It was a physiologically low glucose, and people went down a rabbit hole that they didn't need to go down. But I certainly, any worries at all about a baby, a glucose level should be part of those very, very early investigations, as should be blood cultures and starting antibiotics. There's more damage caused by untreated infection than there is by untreated hypoglycaemia. And as I said, the two often go together.
Yeah, and again, I think there've been some comments backing up what you've said, that mothers are often reluctant to hold on to their babies for extended periods of time in skin-to-skin mode. And when it's suggested that this happens, let me say, women fail to understand the importance and feel that staff are being unsympathetic. So perhaps this goes back to antenatal education.
Yes, yeah, and actually there's nothing more lovely than holding your baby. I had friends who had twins 22 years ago, much wanted twins, born by section at 37 weeks on the unit where I was working. And I went to see them, and of course, because they were so wanted, every uncle, aunt, grandmother, friend, godparent-to-be, they were all coming in, they were all cuddling the babies. And I just had to start to be the bossy doctor. And I said, actually, if you want to feed these babies, get rid of all these people and hold your babies, because the babies were being passed around, they were being settled by people holding them, and the wrong person was holding them. So we actually banned the visitors so that she could concentrate on breastfeeding.
Yeah. Right. I think that might conclude all of our pre-submitted and questions live throughout this morning's webinar.
Yeah. So I'm just very conscious that I have asked you to go and do your homework. And one of the reasons for that is that we all know that by reading something ourselves and studying something ourselves and thinking about how it applies to our own practice is more beneficial. So read the framework for practice, read, if you want to, the learning from claims, read the attain work, and if you're working on a neonatal unit, think about, or a maternity unit, think about what you're going to take back to your own unit.
Great advice. Thank you very much, Jane, and for your time. And I know you had a little interruption earlier, but actually it was less than 2 minutes, I think. Which is not surprising, actually, given your role. But thank you again for delivering what was a fascinating webinar. Thank you all for joining us, those of you who joined live on the day, and many of you will watch this, I hope, when the recording is sent out. On the screen now, you should be able to see a slide, which is a link to owenmitchell.com with the webinar archive for Maternity Matters and others. And at the end of the recording, there'll also be a link to the Maternity Matters Hub, which will give you some details of forthcoming webinars in this series, both bite-size and longer form. The next of which is on the 12th of October on Group B strep infection. Please also let us have your feedback. There's a feedback form in the Q&A at the moment, and do please complete this. It helps us to formulate and to devise future webinars. And if there are any further questions, as I say, do email and we will try and address those separately and respond. Thanks, everyone. Hope you have a lovely day wherever you are. Bye-bye.